All right, hypoglycemia. Um, this really goes into more of reactive hypoglycemia, and these are the three things that three topic areas that are going to get covered in this. Controversy and diagnosis, glucagon and insulin, and hypoglycemia is multifaceted. Um, so let's start with the controversy and diagnosis. So there are lots of different symptoms of reactive hypoglycemia. People can report being shaky, irritable, they need to eat frequently, dizziness, trembling, sweating, hunger, fainting, nausea. Does anybody have any history with reactive hypoglycemia?
I just, I was around my dad who was diabetic and things like that would happen. But myself, one time I was shopping with a gal on a ranch in Texas and I didn't eat and I ended up going into the gas station bathroom, leaning against the wall and just kind of sliding down because I was so empty and dumb. This was like 25 years ago. I thought, I think my blood sugar was low and it feels like crap.
Yeah, I growing up, my teenage years, I definitely had this. Like I needed to eat frequently. I would get very dizzy, break out into a cold sweat, just feel very shaky. And, it was a thing. Like I just needed to, and it was just, I don't know if I got diagnosed. I don't know what it was, but yeah, just people are like, oh, you're having low blood sugar. You need to eat. So. I know it can happen a lot just for teenage girls, just going through that hormonal shift can cause it. So that's a time that where a lot of women will report that during those teenage years, and then it just kind of self-resolved, really. Um, but hypoglycemia, low blood sugar, I just asked you that. What do you guys know about it? Um, There's hundreds, probably thousands of studies, and they show that the term reactive hypoglycemia, there's no specific, they can't pin down parameters that match. So all the studies that they've done on this, all the symptoms, they don't line up with specific biochemistry markers. So there's enough people that have the symptoms, whether their blood sugars are high or normal, or low, that they really can't pin down what this it's just a label, right? So physiologically, low blood sugar doesn't always cause the symptoms, and people with optimal or even elevated glucose levels still can say that they have all those same symptoms. So, what happens when symptoms don't line up with markers and we label something, but it's just a label? We do this a lot with SIBO, right? People have constipation and diarrhea and some level of dysbiosis, and we go, sounds like SIBO. And it's just a label, but we need to go back and find out what's really happening with the person. Um, and what happens when we have clients that come to us with symptoms that, you know, and they've said, I suffer with low blood sugars. Um, so let's go back to insulin and glucagon. There's a whole talk that she references during this call about another conversation they had on this topic specifically that's a little bit of a deeper dive. That's the one I was trying to find. Um, that I haven't found yet. So I will do a deeper dive and see if I can find that because I don't think it's like linked in my list. Um, but the actions of glucagon and insulin. So when insulin is secreted, glycogen is stored and it inhibits the hepatic production of glucose by suppressing glucagon. And then the opposite happens. When glucagon is secreted, glycogen is broken down and the supply of glucose increases, goes up. And GLP-1, this is why I think Debbie might get some info in here on your client. GLP-1 drives insulin secretion. It's located in the duodenum as an incretin, just like you mentioned GIP, is the same thing, and it works just like CCK and biostimulation. So when insulin is high and glucagon is suppressed, our main consideration is that low blood sugar can either be caused by glucose disposal, right? That the body's just taking up more glucose into the cell, so you end up with a lower glucose number. But it also could be that you have lower production in the liver of glucose, so that gluconeogenesis doesn't happen. So, can we increase GLP-1 naturally? And we all know, I mean, and this is funny because this was done, I think it was just when all these GLP-1 things were just starting. So in the current study that she was reading, we conclude that certain herbal-based constituents such as berberine, I'm assuming that's green tea, curcumin, cinnamon, wheat, soybean, resveratrol, and gardenia all can exert an influence on GLP-1 release. So, what happens in our clients who are doing these things? And maybe they're taking berberine for a different reason, but maybe they're just taking it to help with their blood sugars and they take it for too long or they're taking too much.
I feel like you impact the gut microbiome.
And if berberine is increasing GLP-1, can you go too far?
Maybe.
I would think so, but I don't know the physiology behind all of this.
Right. So GLP-1 or GLP-1 are agonists. So things that increase GLP-1, these are all the things that they can do. Um, they're going to decrease gastric emptying, decrease GI motility. Um, it's going to decrease blood pressure. So what happens? You're taking maybe lots of berberine.
And she's actually experiencing low blood pressure and she's passing out.
Mm-hmm. Yeah, so maybe that needs to see. This is the thing that happens, right? You're supporting her foundationally. Things function is returning, but she's taking medications that are impacting function.
Mm-hmm.
And is it too much of a good thing?
Mm-hmm.
You know. So, when we have patients that have this reactive hypoglycemia and they're having they're having the symptoms, right? That we consider reactive hypoglycemia, are we just maybe doing things that are increasing GLP-1 and causing problems? I guess is, what we need to figure out. So here's some various scenarios. Too much insulin secretion, high sensitivity at the receptors, dumping syndrome, inflammation or infection, and H. pylori overgrowth. Do you know the common denominator in all of these different scenarios? What's the common thing?
Is it the inflammation?
Nope.
High blood sugar?
Stress.
Increased cortisol?
Yeah, I say stress.
So the common, go ahead.
I was going to say stress, which in turn increases cortisol.
Mm-hmm.
So all of these can have GLP-1 as a factor. So in high sensitivity at the receptor, GLP-1 increases insulin sensitivity and suppresses glucagon. In dumping syndrome, a lot of times we just jump to dysbiosis, right? Like, oh, there's got to be something going on in the gut, microbiome is off. But dumping syndrome can stimulate GLP-1, um, and you can end up with that. We go into it a little bit further because people were having trouble making the connection there. So there's another slide on dumping syndrome. Inflammation or infection can stimulate GLP-1. GLP-1 in some studies has anti-inflammatory properties. So as you have cases where you have more inflammation or infection going on, you can end up with higher GLP-1. H. pylori overgrowth. A lot of times you'll end up with this is iron deficiency anemia, which leads to poor carnitine production, which leads to poor gluconeogenesis. That all has GLP-1 involved. And then this is that stress, the too much insulin secretion, and the emotional and perceived stress that can drive that. So dumping syndrome, they had a whole conversation about dumping syndrome, and dumping syndrome has to have a lot of water behind it. So a lot of times your client can be drinking a lot of water. It's going to cause really thin chyme in the body. Then it comes out of the stomach and the body has to do something with it. It's not something it can handle. So the body needs to move it out quickly. So in these cases, using things like glucomannan or psyllium husk gums and different fibers, even the mastic gum, can thicken that chyme and help prevent that dumping syndrome from happening. But we have to look at the whole picture behind what's going on with our clients. So once again, when insulin is high, glucagon is suppressed, and the body and the liver specifically is not making glucose. So why is a person whose blood sugar goes super low having these symptoms? Um, and it goes back to just figuring out. There could be clients with low cortisol. They're waking at night because their blood sugar is going low. Is that correlating with their symptoms? And if studies show no rhyme or reason to these reactive hypoglycemia spikes, the question that the conversation and the question that Jen had around this is, what is the body really doing here? And is GLP-1, we're all focused on everybody being deficient in GLP-1 and increasing it, but what if the we've already pushed the limit and it's the opposite that's going on in some of these clients? It was basically the conversation that was happening. So is there another route to consider? Is this something that you need to look at? And with everything that Jen says and everything, we have to go back to, is there the sufficiency of nutrients and minerals to handle all the different things the body needs to do? So we aren't trying to fix it. We're looking for a reason for it and working through the PATH method, looking at diet, looking at hydration, looking at minerals, and trying to figure out where is this body in lack and and why. When the body's working in a proper manner and glucose is taken up into the cell, um, right? That's the best scenario. But we also have those clients where they're not getting glucose taken up at all, right? And their blood sugars are going high. But once we restore foundations, we may never find out at all. I don't know if you guys, we're always looking for the reason why, but sometimes things just resolve for no apparent reason. But, right, Deb, right, you've got it. You've got clients where you've done the foundations, right? Their symptoms are down, and now we're digging deeper into the reason why. But now that their symptoms are down and they've got some straight foundations in place, and maybe their blood sugars aren't going as high or as low, now when you go back to look at their blood work, you may see patterns may emerge that you weren't able to see when things were so wonky. So it's more of walking people down the path and letting them know that we may never find out exactly what this perfect storm was that put you in the place you were at. But instead of looking back and trying to retrace our steps, going forward and saying, but we do know what this body needs to heal, right? And putting those in place. So I'm going to look for that glucagon insulin talk. But I thought it was an interesting perspective on the GLP-1 that we hadn't, because we're all focused on increasing it. But, going back to the slide, that one, right? And if somebody's got too much, what's the opposite physiology that's happening in the body driving that?
That's a
You know
good
what?
slide to have.
It's a wonderful slide. You know what's so interesting about this is and I'm part of a group out of Canada, Alicia Edwards with horses.
Hmm.
And I might have mentioned her before, but she said diet is the number one thing to look at, and toxins, of course. But um, she's gotten, there's metabolic horses and insulin resistant and Cushing's, and she's actually gotten them just with these decreasing stress and a simple diet change, nothing major. These horses will over
Well,
12 months get better.
the every single one of my patients just usually diet and just a few increase in supplements for some nutrients give them 75 to 80% of their symptoms decrease. I
Isn't that
mean,
awesome?
I have that over and over and over again, which is why I point it out to them,
Hmm.
because I tell them anything else that we do is just going to be small incremental changes. There's
Mhm.
nothing that's going to be as impactful as that.
Right. Well, and once you know, right? Like, okay, so we're increasing these vitamins or we're adding these things in, right? As a crutch until we get the foundations in place, right? Because you want your clients to feel great. You want them to have that symptom reversal, but you want it to stick, right? Which is why, I mean, I think that's where the longevity of being able to work with them through all the different foundational pieces and making sure that, yeah, we made a really great, hit at this. Now you've got the energy. Now you've got, the stuff in place. Now it's practicing what you preached and putting those in for the long haul and then teasing out the other things, which happens so much better when they're hydrated, right? And when they have mineral sufficiency and their body's actually digesting and absorbing nutrients and getting rid of things.
It's so fascinating. Hey, Deb and Joe, I have to ask you this question. Is the GLP-1, is that the diabetic drug that can cause that? It's a bad infection in the perineum, genital area. Is that the drug? One of those drugs?
No, you're talking about the like the Januvia and that kind of thing that causes you to lose glucose in your urine.
Oh, is that why they can get a
Right.
bad infection down there because there's
Yep.
constant sugar being peed out? I was always
Correct.
wondering what was
Bo,
going
I'm
on.
going to step out for a second and check red. I'll be right back.
Thanks, Deb. I just couldn't remember which one that
Yeah.
was because a friend of mine, well, the people that have the horse farm where my horse is, she said, "What is this? All the ads on TV where it could cause some awful
Yeah.
infection."
It's called
Yeah.
a DPP4. It's dipeptyl dipeptidyl peptidase inhibitor.
Okay. And don't
It's
they call it,
abbreviated DPP4.
okay. I remember a few years back when I was still practicing, they talked about that. But I can't remember the term they used. It almost as like as a gangrenous type infection in that area.
I mean, it's basically you get a yeast infection that then gets infected with bacteria.
That's what it is. Okay.
Mm-hmm.
That would be awful.
Because the yeast is feeding off of the sugar that's in the urine, right? And
Hmm.
then when you have, the break in the skin due to the yeast infection, then, the opportunistic bacteria then take hold.
That's okay. And that makes sense. Yeah, I've seen some, not from that, but I've seen some horrific yeast infections over the years. Even in a baby, that some of the diaper rashes, it's like, oh my God.
Mm-hmm.
Yeah.
Mm-hmm. Yep.
Thank you. I was just kind of wondering if this was the one, but I got the wrong drug.
Mm-hmm.